Okay, so again, we have 3 pages of symptoms that we're not going to go into, but basically, I think you're nursing a bruised spinal cord. You can't tolerate an MRI, but I think that's what we would end up finding here. And why do I think that? Okay, so here, looking from behind, you have a hypoplastic right jugular vein. The atlas is up to the right. C2 spinous is to the left. You can see how this joint capsule is slid forward on the left. It's back on the right. On the left side, you can see the head leans to the left. That joint capsule or that joint space is closed compared to the open one. We swing you around. Yes, we have this elongated styloid, which is also a sign that there's some hypermobility in there. Yes, it comes across the internal carotid. The other one goes in front of the jugular. When you bring your head down, you have some room in there, so it doesn't close off quickly. That's not what we're talking about here. What we're talking about is right here. So all the blows to the head, all the traumas, we see that the odontoid is the odontoid relative to the atlas is close to the right. Think of this space in here, or that joint surface, as being normal, and this is the part that's adapted, and this calcification of a joint capsule or a callus type of formation on the bone. And we looked at this quite a bit, and what we've come up with is that C2 is slid forward, atlas is slid forward on the left. Think of it as a car where the left rear tire has a lift kit and is pitching everything forward. So again, prolotherapy, which you've already gotten some great results back and through here to pull this thing back down. We adjusted you today from actually we'll show you that in a minute, anterior from the left. So here we have left head rotation. You can see how the odontoid tries to get into the center. It shifts, slides across. Now there's a transverse ligament that goes across here. There's also a joint capsule in there, which is not demonstrated here. So this is normal anatomy. There's your atlas. There's C2. There's the collateral ligament, and there is a joint capsule that swells up. So we see with other people that it will swell up and actually occupy space. And there's not a lot of room in here for you to have something swollen and occupying space, which I can assure you is happening right in through here. So you've had repetitive injuries where you're having to do a job where your head goes to the left and your head goes to the right like 1,000 times, and that's going to light this thing up, swell it up. This odontoid sliding back and forth, doing things that are going to confound a lot of your doctors and give you some symptoms that are confounding, quite frankly. Okay, so this is left head rotation. You can see how the odontoid tries to get in the center. This is right head rotation. You can see how the odontoid bottoms out there. And here you can see a good shot of that callus formation. And normal joint capsule, and then that adaptation. Let's move that out of the way. Okay. All right, so this is what you look like on X-ray. You can see that built up callus. And it almost even looks like the odontoid broke off at some point and then reattached in some way, but I think that's just an optical illusion. The posterior arch of the atlas is coming across there. But that actually was a thought for a moment. Here's a weight bearing looking down from the top. We see that the atlas is slid forward on the left. And the contemplation was to come from the right to open up this acute angle, but really the highest priority is this anteriority, and let's see if we can get some good shot. Here we go. Okay, left head rotation showing how far C1 comes off of C2, a little too much. Showing how far the atlas goes up to the right with left head rotation. Neutral, I'm sorry, that's left head rotation. It gets more in the neutral position. Oh yeah, this is an enthesopathy that I found. So this is a calcification of I think it's the transverse ligament that's trying to stabilize. So it's just trying to come across and eventually trying to get across all the way. That's the evidence there. This is somebody else's MRI, just to let you know what the joint capsule in there looks like and the transverse ligament looks like. So this will swell up and put pressure towards the cord. And actually what it does is cause turbulence. The spinal cord will shake back and forth like a water pipe with turbulent water going through it. And that's, I think, what you've had. You've had exacerbations to where you have to lie down for days. And I think that's kind of what you did just by moving your head and turning, not to mention some other therapies that people have done to try to help you and weren't aware of this. Oh, that's a movie. You can look at that later. Right head rotation, C1 coming off of C2 too much. Styloids trying to stabilize you. Yeah, this is a great case where the styloids are the secondary, the hypermobility is the primary, and you need to hold on to these styloids. Right head rotation, yeah.
That's the first I've ever heard some cases like that.
Yeah, no, you're right. Look how much, I mean, this thing is sliding back and forth like a typewriter. Again, I showed it small, how it's closed on that side, open on the other side. Yeah, and the question was, when you bring your head down, is the styloid actually contacting the atlas and rotating it? I don't think it is. I don't think we're getting that far. There's another shot how far the atlas has gone up to the right. And we actually didn't come from the right today. We went from the anterior on the left. Again, more enthesopathies. So some would argue that you were born with a spatulated transverse process like this. I think it was a nerd over time and calcification. These two approximate each other. I think we're looking at a crime scene here and trying to evaluate what happened, being detectives. So you have a hypoplastic right vertebral artery, and I was interested if that's coming into play. But I mean, just look. This is the neutral position. Look how offset everything is. This is the murder weapon up there. All right. So this is an inventory of everything. Possible entrapment of the vertebral artery with head extension, big offsets, enthesopathies, sliding forward, sliding down on the left. I did grab a snapshot of some interesting anatomy. You have a couple of arteries coming off the left vertebral artery in a unique way, and they're coming off real close, real low, right by the atlas. I just thought I'd document that. Again, here I was showing how the atlas is actually bottoming out in the skull. The skull, it comes to a bony stop there. That's bone. Yeah, so that little space, that's the bone of the atlas touching the skull. Another shot looking down at the main trauma. Again showing looking down from the top. Okay, so here now you can understand why I've decided to go anterior from the left to open up the dominant vertebral artery and to try to bring this back around, to bring the load back to the left posterior aspect. We want the weight of the skull to come back. So we brought this back from the left. There's another shot of it. That's why you're feeling better. And of course the question is, surgery or no surgery? Well, that's not my call to make. We're going to send you to people that are going to help you make that decision. I'm glad you got response from prolotherapy, just tightening up and making you less mobile. But whoever fixed this, this is an aerial view. It was just so offset. And there's another little piece of calcification. I always kind of take an inventory of where somebody might have a CSF leak, so that was I just captured that. Left head rotation, right head rotation, just seeing the odontoid slide back and forth. So when you turn your head to the right, the atlas goes up to the left, not too much. That actually is your MRI, and I quite honestly didn't even recognize some of these structures in here. I'd like to get a better quality MRI on you. Just some measurements. Yep, documenting that. Oh, yeah, we found some calcification in the front. Again, body's trying to stabilize this hypermobile thing. Any questions?
No, not at the moment.